for 2021. We held our first event last year remotely, and actually previous years we'd held these face-to-face, and last year we realised that we can access more people and also record the events so people can use them and see them whenever they want. So over the next probably just over an hour, we're going to provide some of the updates on the work that we're doing here, and a little bit about the background of all of the different types of work that we do here, but with a focus on the session on IgA vasculitis. So welcome. I'm just going to begin to share my screen. Hopefully everybody can see that. Is that okay, everybody? Yep, great. So yes, welcome to the session. So just as an introduction, I'm Dr. Louise Oney. I'm a paediatric doctor based at Alderhay Children's Hospital in Liverpool, and I spend half of my time doing research with the University of Liverpool and half of my time in the NHS at Alderhay. And I have an interest in inflammatory conditions, and in particular those conditions that affect the kidney. So over the next, let me just shrink this down. Over the next hour or so, I'm going to just do an introduction on the condition, and also about our EATC centre here and what kind of work we do, because I work as part of a much bigger group who look at other diseases in children. Then I'll focus a little bit on what is IgA vasculitis or Henoch-Schönlein purpura, and then some updates on this. And then I have one of our excellent students, Chloe, who's going to present some of her work, which is looking in urine and how we can understand some of the immune system in children with IgA vasculitis by looking in their urine. Rachel, who's one of our scientists, is going to be looking at another part of the immune system called the complement system, and she'll explain how that could be important in this condition too. And then I'm going to summarize just by talking about what the future might bring, and how you as patients or families or parents can get involved in some of the work that we do here. So just as an introduction and to set the scene about what the EATC for children is, first of all, just to mention that IgA vasculitis was renamed quite a few years ago now to use the kind of more biological terms instead of the name Henoch-Schönlein purpura, which was named after doctors back in the 1800s who invented the disease or discovered the disease. And actually the two names are used interchangeably. So people use HSP or Henoch-Schönlein purpura the same way as they use IgA vasculitis, and they mean the same. It's really just that doctors are trying to move towards names that represent the biology of the disease to try and allow us to understand it a bit better. But throughout the talks, you might hear us referring to HSP, or some of the work that we present that could be a bit older will refer back to HSP, but either names are absolutely fine. So who are we and what is the EATC? So I work as a part of a much bigger group, which is what we call a translational group of scientists, doctors, administrators, patient involvement people, students. And part of this, we form this centre called the Experimental Arthritis Treatment Centre for Children. And we're based at Alderhay in Liverpool. And we've got a really nice animation that explains the work that we do much better than I can. So I'm going to just see if this link will work, and hopefully it'll take you through to our YouTube animation, and this lasts just for a few minutes to explain some of the work that we do here.
EATC 4C stands for the Experimental Arthritis Treatment Centre for Children. It was started in 2014, following an award by Arthritis Research UK, now Versus Arthritis, and funding from the University of Liverpool and Alderhay Children's Charity. It is the first and only one for children in the UK. Its main goal is to improve the health and well-being of children. So let's look at each word to understand what we actually do at the EATC for children. E. Experimental. Experimental means simply we test new and different treatments for children, and there are different ways to do this. Studies may be based in the laboratory, where we look for biomarkers, which are molecules that occur naturally in the body. These biomarkers might predict disease flares or drug responses. We also perform early phase clinical trials, testing promising medicines that are often used to treat similar conditions. Our goal is to find and test better, safer medicines for children. A. Arthritis. Arthritis is just one of the conditions we are trying to treat. It is an umbrella term and actually includes a number of inflammatory, autoimmune and bone and joint conditions, including juvenile idiopathic arthritis, or JIA, JIA-associated uveitis, juvenile onset systemic lupus erythematosus, bone diseases and scleroderma. Most people don't realise that children can get these conditions too. TC, Treatment Centre. Although treatment centre implies a building, we are actually a group of people spread throughout the UK, in Liverpool, Bristol and Sheffield. Within this collaborative group, we train new doctors and scientists. We also partner with industry to trial new medicines in small patient groups and collaborate both nationally and internationally. 4C, for children. Children and young people are at the heart of what we do, and ensuring that they remain at the forefront of our research is our number one priority. We work closely with children and their families to understand what is important to them. This means getting them involved in all stages of our research, including planning the studies, developing the patient information sheets, and even helping develop animations. The team of people that make up the EATC for children are based in 3 cities. Bristol is led by Professor Ramanan, Sheffield is led by Professor Bishop, and Liverpool is led by Professor Beresford. Liverpool is the main hub for the EATC for children, where we have a large team of clinicians and scientists working side by side. This is what makes the EATC for children special. The expertise of our team members and all of our different disciplines make us strong and able to produce effective research to improve the treatment and care of children. Some of our work starts in the lab. Our scientists are looking for molecules in the body that might tell us if you are going to get sick or when you are getting better. Then they look at ways to use these molecules to identify better treatments or tests. When new treatments are discovered, we undertake a clinical trial to test the treatment and show that it helps fight the disease. We might also perform a study to gather information about children with certain conditions. By learning more about the disease, its symptoms, and the children that get it, we can try and identify ways to treat it, which could lead to another clinical trial. The aim of all our trials and studies is always to make children feel better and improve their conditions in order to help them get back to school, friends, and family. All of the work carried out in the EATC for children is inspired by and involves all of our children, young people and their families. Our team also takes research activities out into the community to inform and inspire the scientists of the future. The major aim of this EATC for children is to allow patients to benefit from new treatments, and the formation of this unique group means that we can take a huge step forward in using early translational and experimental medicine to treat childhood arthritis and related rheumatic and musculoskeletal disorders. Visit our website to find out more, our Twitter to find out about upcoming events, or contact us directly.
Excellent. So let me just turn back to our slides. So great, that hopefully gave everybody an overview of the work that we do. And within the EATC for children, we have work streams, some of which were mentioned, and an emerging work stream has been over the last few years our work stream on immunoglobulin A vasculitis, which we're going to focus on now. So just to go into the condition a bit more and then talk about some key updates before we move on to hearing some of our exciting science that's been happening. What is IgA vasculitis? Well, IgA vasculitis usually presents with a really quite striking rash, which is often on the legs and the arms, and is the type of rash that doesn't go away if you did the glass test. So if you pressed a glass against the rash, it's what we call a non-blanching rash, and it wouldn't disappear. And this usually means that young people or patients who have this condition will present to their doctor fairly quickly because the rash can be quite striking. But we know that it also involves other organs in the body, and it can involve the gut, and they can get sore gut or tummy pain or inflammation. And about 6 out of 10 patients will get their gut inflamed or involved. We see sore joints, which are usually the ankle or the feet, sometimes the knees, and these can cause what we call arthritis and inflammation in the joints. And about 6 or 7 out of 10 people will get joints that are inflamed at the time of presenting with IgA vasculitis. And then we also see kidney problems, and these are usually picked up through the urine, and about half of our patients will have some form of kidney problems during their course of IgA vasculitis. So IgA vasculitis is inflammation of the very small blood vessels in the body, and doctors split up how we classify inflammation in the blood vessels by looking at the size of the blood vessels. So we have what we call large vessel vasculitis, medium vessel vasculitis, and then small vessel vasculitis. And so in the very smallest blood vessels in our body, the smallest tubes or pipes that carry the blood around the body, is IgA vasculitis. And who gets it? It's a condition that we see most commonly in children. It's usually slightly more common in boys than girls, and this is similar in adults who can get the condition. And what we see when we look here is a graph at the number of patients. And this was a really big study where they looked at lots of different conditions in children. And this top line here is IgA vasculitis, and across the bottom is age. So as children aged over here, you could see how old they were when they presented with IgA vasculitis. And what you can see is that the peak age of patients presenting with this is around about primary school age, so 6 to 8 years old. But it can present at any age, and we see teenagers and adults who can present with IgA vasculitis, but it's less common than those who are in perhaps primary school years. And there are differences between adults and children who have this condition. It can present at any age, but we commonly see it presenting in children. Because it's less common in adults, there are reports of a delay in the initial diagnosis for adults who get the condition. Children often have less damage on their kidney biopsy, and it can be that it's more inflamed, but there is less what we call scarring in their kidneys compared to adults who might have older kidneys, and that they might scar more easily. Adults are also described in our medical reports to have more joint problems than children, and children have more tummy problems than the adults. We also see that children usually respond fairly quickly to treatment, and this might not be the case with adults who have perhaps more difficult disease to treat. But we sometimes see that because this is more common in children, those children who have disease which is not as straightforward as others might have a delay in then reaching the specialist care that they need. And this is an area that we're keen to improve. So how common is it? This is quite a complicated page really, but what we can see here is two pie charts. And this one here is looking at children and looked at lots of European children who had lots of different causes of vasculitis. What we can see from this pie chart here is that this big chunk here is IgA vasculitis. And so when we look at all the different types of vasculitis in children, it's by far the most common type of vasculitis that we see in children. And this is very different to adults, where this is the pie chart for adults with vasculitis. And what we can see is that compared to other types of vasculitis, this is HSP here, and this is a very small proportion of the type of vasculitis that adults get. And so we can see that there are differences between children and adults with this condition, and that actually it's a disease that's quite familiar to pediatricians because they see it much more commonly than adult doctors might see it. So how do doctors diagnose it? Well, we have internationally agreed classification criteria, and this table here gives what looks like complicated criteria, but really what we use to diagnose it is the presence of the rash, and this rash being the typical rash that doesn't go away with the glass test and is mainly on the lower limbs. And together with another one of these, so either that they've had tummy involvement, that they've had a skin or a kidney biopsy which shows the IgA molecule, or they've got arthritis or joint involvement, or they've got kidney involvement. And what the literature and previous doctors who've done the studies to look at how good these criteria are, they've shown that they're actually really good in being able to pick this apart from other types of vasculitis in children, with tests that are almost close to 100% when we do tests to look at how good they are. And so we use these to diagnose the condition in children, and there isn't a specific blood test or laboratory test that we can use at the moment that can tell us whether a child has HSP or not. So are there any triggers for the condition? There are. What we see with IgA vasculitis is that it can vary throughout the seasons of the year. And so this was a very, very large study in Japan that looked at over 16,000 children. And what they looked at is when IgA vasculitis presented throughout the year. And you can see here with this graph, this is the number of patients. Ooh, hang on a minute. I think there's something on YouTube that's playing in the background. Sorry about that, everybody. Let's get back to where we were. So here you could see that the number of children that presented over a year period, so this was January right through to December, did change, and that there were peaks in the kind of winter and spring months, and then a dip in the summer months. So it's more common over the winter months and spring and perhaps autumn than we see in the summer. And what this study did is that they linked it with different types of viruses in children, and they saw that there were different types of viruses that correlated with IgA vasculitis, suggesting that viruses in children can sometimes be a trigger for the disease happening. And this study was presented back in 2018 before the coronavirus pandemic. But you can see that even in this table here, coronavirus is included and is known to be a trigger for IgA vasculitis. And therefore, it's not surprising that some people are reporting that they've had coronavirus and then they get IgA vasculitis, because this has always been known to be a trigger, and other types of viruses can also trigger the condition. So other triggers that are recognised include ear, nose and throat infections, and these are seen fairly commonly before the onset of IgA vasculitis. About a third of patients will have had recurrent tonsillitis, and about 1 in 10 would have had ear infections. And we also see that there can be triggers with teeth, so dental infections or poor dental hygiene can trigger this condition. And also less commonly in children, and perhaps more commonly in adults who might already be on medication, is that some medications and sometimes vaccines could trigger this onset. So what actually causes IgA vasculitis? Well, what we see is that this IgA molecule is actually in your saliva, in your gut secretions, and it helps to protect your body from infections. So normally, if you had an ear, nose and throat infection, then your body would release more of this IgA to try and clear the infection in the mouth or throughout the gut and try and protect you. And it's one of your first lines of defense in your immune system. And what happens in IgA vasculitis is that IgA molecule that's produced is thought to be abnormal. So it's a different version. And so the immune system reacts and thinks that it's an invader and forms what we call antibodies against this IgA. And then that circulates throughout the body in what we call immune complexes. And we also find the abnormal levels of the IgA in the body. And these are what can cause the problems then with the inflammation in the blood vessels. And what happens for the majority of patients, they get better in less than a month, but a small number will go on to get kidney problems. And we know that about 1 in 4 will get relapses in the first year. And after that, some patients will continue to get a recurrent persisting disease that might need treatment. And so even though the majority get better, we do know that there are some that will go on to get some complications from the condition. And what are the main complications? In the short term, we see problems with pain, and this can be pain in the skin, in the joints, or in the tummy. And we also see problems with gut inflammation that might need patients to go into hospital if they've got severe tummy pain, or they've got vomiting, or they've got blood in their poo, or more severe complications of their tummy. In the longer term, the main complications are related to the kidneys and having kidney inflammation. So this is a slightly complicated picture here, but this looks at how we think about treating some of the complications in IgA vasculitis. And in most patients, it self-resolves, it gets better over time, and they don't need any treatment. In people who have severe skin involvement, so if the skin was blistering or breaking or really sore, then doctors might consider a short course of steroids to make that better. If there was severe joint problems, so people weren't able to walk on their joints, or severe pain in their joints, then generally it's recommended to rest them, to use pain relief, and sometimes the use of anti-inflammatory medicines are used. If the gut was severe, so if there was severe abdominal pain or bleeding in the gut, then there may be a role to do a scan, so a tummy ultrasound scan to have a look at the gut and to check that it's okay, and also to consider a course of steroid medication. All people who present with IgA vasculitis have to have kidney monitoring for at least 6 months. And that's because the kidneys won't present with any signs or symptoms, and the only changes that we'll often see are in the urine. And so everybody has to have 6 months of screening in their urine. And if that's normal after 6 months, they will then be discharged. But if there's signs of kidney inflammation, then we'll go on to do more tests. And I'll talk about that in a bit more detail in the next few slides. So how do we manage the kidneys? As I said, everybody gets their urine screened for at least 6 months to check that that's okay. And we do this using different monitoring ways. And at the moment, every hospital does a slightly different way of monitoring the urine. And this is something that we're trying to make better and make everybody do a similar one so that we all know that we're doing the same monitoring. But what we found when we looked at our monitoring a few years ago is that if the urine's okay in the first few weeks, then it's likely that it's always going to be okay, and that actually there aren't going to be any serious kidney problems. And so usually in the first few weeks, we can tell whether somebody's going to have serious kidney problems or not. But at the moment, all of the monitoring continues for 6 months regardless, because that's when we can be absolutely definite that there aren't going to be any further kidney problems. About 10%, 1 in 10 children will go on to need a kidney biopsy, and then they might need treatment for kidney inflammation. So when do we treat? We could treat all children when they first came with IgA vasculitis to try and see if we can prevent any of the complications or prevent the kidneys from getting inflamed. And what we know from really big studies that have been done is that if we treat all patients when they first come with steroids, it won't prevent the kidneys from getting inflamed. So at the moment, there's no role for treating everybody who has IgA vasculitis. And that's because there are some patients who are going to get better and their immune system will get better even without treatment. So during the screening and the checking of the urine, could we treat them when there's early signs of the kidneys being inflamed? And this is something that we don't know at the minute. We don't know whether we can detect very early on those people who might have further kidney damage in the next few weeks. And what we're trying to do is look at some of the biology and some of the science in the laboratory to try and see whether we've got a role for treatment in this group of patients. And that's something that the following speakers will touch on. So at the moment, our treatment for the kidneys is based on when the kidneys are quite inflamed and that we've done the kidney biopsy test to have a look at that inflammation under the microscope. And we have big literature studies that have looked at the treatments that we use. And when they've looked at this and tried to go through all of the data that's available, there really isn't very much data to support what medicines are best for this condition and what medicines might be the very best ones to work compared to others. And so there are recommended medicines that we use, but it might mean that every doctor will use something slightly different to other doctors. And what we're trying to do really is to treat those who are going to go on to get kidney problems that can be more severe, and bearing in mind that lots of people will be absolutely fine and don't need any treatment at all. And so the treatments that we use are generally treatments to calm the immune system down, and these include very big doses of steroid medicines that can sometimes have side effects which patients have told us they don't like, as well as other immune medications that dampen the immune system. And these are all very broad spectrum medicines that calm the entire immune system and don't act specifically on the disease pathways. We can also use medicines to reduce the amount of protein leaking from the kidney called ACE inhibitors. And if needed, we can also treat other stuff that help the kidney, such as high blood pressure or if there's fluid swelling. And we can consider steroids if there are severe problems with the skin or tummy, like I've mentioned before. So just to summarize from this part of the talk, IgA vasculitis is when the very small blood vessels in the body get inflamed, and it's what's called an autoimmune condition. So it's something where your own immune system has developed antibodies or developed an attack against this abnormal version of IgA. It's the most common type of vasculitis in children, but it can present in any age, including teenagers or adults. And at the moment, the treatment is focused on the kidneys, and there isn't a role for treatment early on to try and prevent or protect the kidneys or protect any of the other organs. But the data that we have for what treatment we use and also for how we target this best is very limited. And what we're trying to do is improve that scientific data and also that medical data so that we know exactly what treatment is best for which patient, and therefore we can treat each child differently depending on how their condition is. And so just to thank you for this part of the introductory talk to IgA vasculitis, and we'll now begin to go in a bit more depth on how we are working to improve this condition in patients who have perhaps more significant kidney problems. And then later on, I'll talk about the future where we're talking about other organ involvement. Thank you. So Chloe, I'll hand over to you and I'll let you introduce yourself. Thank you.
Thank you. Can you see my screen okay? Hi, good morning everyone. My name's Chloe and I'm one of the research students here at the EATC. And today I'm just going to be talking a little bit about what my project has been over this last year and what I've been up to. So just to tell you a little bit about me, so I joined the University of Liverpool in 2016 as a medical student, and this was me all the way back in first year when I got my first pair of scrubs. And I really thought that I enjoyed research, and when I moved into second year, I actually started a research project with Dr. Oni at Alderhay, and that was looking at a particular antibiotic called vancomycin and the effect that it has on the kidneys in children. And this project continued into third year, and I managed to present this at a conference when I was in fourth year. And in fourth year, we have the choice to take an extra year out after, just to do an extra year of study. And for me, I wanted to do a bit more research, but other people choose to do medical law or a further study for anatomy. But I really wanted to go back to Alderhay, so I joined the team last September, and this has been me this year doing some work in the labs and working from home as well. And then finally in September, I'll move back into my final year and I'll end up graduating as a doctor. So just to talk a little bit about my project, the overall theme of my project has been looking at ways of measuring how active somebody's HSP disease is. And the ways that we've been doing this are looking at biomarkers in the urine for detecting kidney damage and developing a scoring tool. So just to give a little bit of background about urine biomarkers, obviously Dr. Oni has given us lots of detail on this, but I just wanted to explain this diagram to kind of emphasize the importance of why we've been looking at biomarkers. So if we had 100 children with HSP, we would think that about 50 of them would get better on their own with no medicines needed at all. About 30 patients we think would have some form of kidney problems, but they would also just get better on their own and they wouldn't need any medicines to make them better. About 18 patients we think would get kidney problems, but they would need medicines to make them better. And then about 2 out of the 100 patients would end up developing kidney failure. And these last 3 groups are the groups that we're really most interested in. And we want to be able to develop ways of finding out which patients might get kidney problems, which ones might get the most severe kidney problems, and seeing if we can identify these earlier. So at the moment, as I'm sure most of you will probably be aware, we currently take samples of urine to look for any protein or blood. And if there is protein or blood and it's there for a long time, then it might be that you have some kidney inflammation. However, the best way that we can look at kidney inflammation is with a biopsy, and biopsies carry risks of things going wrong, and it's quite a big procedure, so it's not really something that we could offer to every child that has blood or protein in their urine. So what we want is another way that's a bit less invasive, of looking, that's an earlier sign of kidney damage. And the best way that we thought to do this was by looking at biomarkers. So a biomarker could be any protein or molecule that's found in either the blood or the urine, which may tell us that something is going wrong. Excuse me, sorry. And most biomarkers that we look at the moment aren't normally available in a routine lab, and they're sort of different proteins to the ones that we normally look at. And we thought that this was the best way to go forward. So the aim of this part of my project was to have a look at the data that's already been published, to find out which biomarkers have already been identified that might be able to detect kidney problems in IgA vasculitis. So when we searched for all of the papers, we used 4 different search engines, and we found 121 records. And of these, there were a few that there were more than one of the same paper, and some of them just weren't really relevant to what we were looking for. And we found that there were 13 studies that were relevant to what we wanted. And over these 13 studies, we found there were 2,446 children, and 51% of those were male, and the average age of them was 7.9 years. And across these papers, we found there were 23 different biomarkers that they mentioned, and 3 were traditional, which pretty much means that we already are able to look for them in the lab, and 20 were novel biomarkers, which means that they're not routinely available. And of these 20 novel biomarkers, we found that 5 were reported more than once, and 4 biomarkers were found to be significantly associated with either predicting kidney involvement or assessing how severe someone's kidney involvement was. And these are the 4 biomarkers that we found. So we have KIM1, MCP1, NAG, and AGT. And these are all just different proteins that are produced from different parts of the kidney. So in conclusion, for the first part of my project, we just found that there are some promising biomarkers in the urine, and they may be able to help us detect kidney damage earlier than normal protein or blood, and may help us to tell which patients might get kidney failure versus those who won't. One of the biggest things we found is that we really need more research into these biomarkers, and there's lots going on, and hopefully I'll be able to get into the lab and we'll be able to test some of the patients that have come to Alder Hey and have kindly given us some urine samples, and we might be able to see if we can find these biomarkers in their urine. If anyone is interested, we've recently published a systematic review on this, and if you want to have a look in any more detail, then it's free to access. Moving on then to the second part of my project this year, we wanted to create a scoring tool and create, develop and test this for patients with HSP. So as I mentioned earlier, we have around 2 out of 100 children with HSP that will develop kidney failure, and that number's not really changed for a number of years now. And as we've already said, we really need more research looking into different medicines that may help these patients. But there's not really one way that we describe patients and the symptoms that they have, and this makes doing research really quite difficult. And a scoring tool would help us and other doctors, anywhere we are in the world, describe patients in a similar way. And it might also help find out which patients are the most poorly and which may need more medicine than others. So at the moment, there is a scoring tool called the PVAS, and this scoring tool is used for all children that have any kind of vasculitis. And because of this, there's quite a few symptoms on there that patients with IgA vasculitis just don't really get. So we don't think that it's a very good representation of the symptoms. So instead, we've created a scoring tool called the IgA VAS, which is more specific to patients and includes a big variety of the symptoms that they might get. Just to break it down a little bit more, so the IgA VAS is a scoring tool that has 40 different symptoms on it, and these different symptoms are categorized into 5 different domains, and overall it gives a total score out of 125. So the 5 categories are, we can see on the right, so we can have skin symptoms, which basically just describes the type of rash and where the rash is. We have tummy and gut symptoms, which includes when you get tummy pain and how bad that is, and then other things like diarrhea and vomiting. It also includes joint symptoms, which might be pain or inflammation, swelling and muscle aches, kidney symptoms, which can help us identify blood or protein in the urine and other markers of poor kidney function. And then finally, we just have an other category, which includes things like having a fever and weight loss. For the methods of this part of my study, what we wanted to do was take a group of children that had come to Older Hay in between 2015 and 2019, and we wanted to use our medical notes to score them using both the old scoring tool, the PVAS, and the new scoring tool, the IgA VAS. So it was myself and Dr. Oni who scored these patients, and then there was another doctor who also scored them using a 0 to 10 visual analog scale, where 0 is happy and healthy and no problems, really completely well, and 10 is the most poorly that they could be. And we then took this data and analysed it and put it into some graphs. The main aims of this project, we wanted to look at, well, does the IgA VAS do what it is supposed to do? Does it identify patients who are poorly? And does it describe them better than the PVAS? The second thing we wanted to look at was, does it correlate with the 0 to 10 scale? And the 0 to 10 scale is just sort of an overall marker of how well the patient is. The third thing that we wanted to look at was whether the PVAS correlated with the IgA VAS, and the PVAS is sort of what we would call the gold standard, so it's the best thing out there at the moment for describing patients with IgA vasculitis. So we wanted it to correlate with that. And then finally, we wanted to look at how similar mine and Dr. Oni's scores were. So I'm just going to talk you through a couple of graphs that we made. So this first graph is looking at, so along the bottom we have the score given for the IgA VAS and then the total score for the PVAS on the left-hand side. And what we can see is that there is sort of a trend of the, the higher the score for the IgA VAS, the higher the score was for the PVAS. And it's a little bit messy, but you can kind of see that there is a bit of a correlation. And then the second diagram is looking at mine versus Dr. Oni's scores. So along the bottom, we have my scores for the IgA VAS, and along the left-hand side, we have Dr. Oni's scores for the IgA VAS. And what we would have really liked to see, if this was a perfect graph and me and Dr. Oni had scored every single patient exactly the same, this would have been a perfectly straight line. But as you can see, it's not really like that. It's a little bit messy and a little bit cluttered, but there is still a pattern there. It's just not as perfect as we'd like it to be. So in conclusion, when we think back to our aims about this part of the project, We wanted to know whether the IgA VAS does what it's supposed to do, and we kind of did feel that yes, it did. It did seem to summarise patients and the symptoms that they have quite well. We also found that the IgA VAS did correlate with the 0 to 10 scale, which was really positive. And as well, it correlated with the PVAS, which is really great, and that's what we wanted to find. However, what we did also find was that mine and Dr. Honey's scores weren't very similar. And this is the main area that we would need to improve on for the future when we think about developing the scoring tool a bit further. So thank you very much. If anyone has any questions, I'd be happy to take them.
Thank you, Chloe. I just wanted to ask a little bit about how understanding the science and stuff is going to help you as a doctor going forward.
Yes, it's a good question. I think it's really helped me to understand on a different level this condition, and particularly how it affects patients and the things that are important to them. I think when we think about research, it always has to come back to the patient and what this is actually going to do for them and how this is going to make their life better. And I think going forward, that's probably the main thing that I will always remember when thinking back to the science that I've done.
Excellent. Well done. Great job. Any other questions?
Chloe, that was a really nice presentation. Thanks very much. I just had a question about your biomarker work. So you say you're going to find all of these biomarkers and hopefully that they will tell you which patient is at risk of developing kidney problems. But how would that actually be tested in a clinical setting when you get to the hospital? What would be the plan?
Yeah, so it's a good question, and it can be a bit complicated because we still don't have a lot of evidence pointing towards one particular biomarker yet. So we would still need a lot more before it was actually used in a hospital setting. The way that we would kind of go forward with it is that once it's been tested in much bigger cohorts, we would then be able to take a urine sample like children with IgA vasculitis would normally have now, send it off to the lab, and they'd be able to test this biomarker in the lab and see whether it was present or not. But as I said, we're still quite a long way off from that, but in the future, that's how it would go about being developed.
Excellent. Great work, Chloe. It's been good stuff for the team. So I think we'll hand over now to Dr. Wright to present her presentation, just a little glimpse of the science that she's been doing. I think you're still muted, Rachel.
Sorry, it's been a while. You think I'd have got the hang of that by now? Hi, I'm Rachel, everyone, and I am working in the research labs, and I'm working on a project looking at a protein called complement and whether that's causing kidney problems in patients with IgA vasculitis. So just a little bit about me. So I am a research scientist. I work in the labs, and here's me using one of our fancy microscopes to just look at some of our kidney cells that we can grow in the labs. And this was taken post-COVID, obviously. So you can see that in the labs now we wear face masks and we wear visors just so that we can protect each other as much as possible when working in the close confines of the lab. So I did my undergraduate degree at the University in Portsmouth. And then I did a master's and a PhD at Queen Mary. So that's just an extra training program to give me more research skills so that I can do research programs. And for the last 6 years, I've been working at the University of Liverpool, but in the lovely building at Alderhay Children's Hospital. And I'm not sure if all of you have had a chance to see our building, but this is what it looks like on a lovely sunny day, and it is a fantastic place to work. And my research has been based on that time looking at damaged kidneys. So I have looked in a condition called lupus nephritis, which affects some children, and I'm also working on now IgA vasculitis nephritis and how it damages the kidneys. And then I also have 2 little ones myself, so I'm a mum as well. So it's a little bit about me. Just realised the date is, oh no, that is right. And So what motivates me? So I have always been interested in science, and that led me to a career in research. I got into translational research, which is what we call it when it has a direct impact on patient care in the future. And I got into that because I really want to fix problems. I'm interested in what causes diseases and how we can fix them. And I particularly got into pediatric research because I think that childhood should be about spending time with your friends and going to school, and it shouldn't be about wondering if your kidneys are okay. And I think if we can fix that for children, it would lead to better outcomes. So the complement pathway. So this is a bit of a complicated pathway, so I'm not going to go into very much detail on it. But what you need to know is that complement is part of your immune system. It's there, it's designed to be helpful. So if you get an infection, it will increase its levels, it will fight the infection, and then it will disappear. But what we know is that in some children, it doesn't go away. You get higher levels than we would expect, and then those proteins which are there to be helpful actually start to cause their own problems. There are 3 of them we're particularly interested in. So there's the C3A, C5A, and the C5b9 complex. And we're just really interested in what they might be doing in this condition. So I've got 2 research questions that I'm focusing on. So I want to know, can the levels of these proteins, the complement proteins, in either blood or urine tell us who has got kidney involvement without having to do biopsies, or tell us at the beginning of disease who might get kidney involvement? So Chloe showed that 50% of patients will not get any kidney involvement, and ideally we would be able to look at this early, and then we wouldn't have to screen as many patients and have people taking so much time out of school and things like that. So that would be an ideal situation. And we also want to know, is this complement causing the kidney problems, or is it a consequence of the kidney problems? Are the kidneys getting damaged and producing this complement? Because if we know whether it's starting or ending the process, that will help us decide how we move forward with the science based on this. So to look at this, I've got some aims for my project. So first of all, I want to look at how much complement is in the blood and urine using different scientific techniques. And then I want to look at what the complement is doing in the kidney and see how much complement is made in the kidney. So this is just going to answer the question of whether it's being made there or whether it's coming there and causing problems. So the way we look at complement levels in urine is something called an ELISA. So this is just a fancy technique we do in the lab. And basically what happens is you get a plate that looks like this, and the more blue, the more protein you have. So these ones don't have very much in them, and these ones have lots. And that just allows us to count how much you have. So this gives us an actual value on how much of this protein you have in your urine, and then we can use that to decide what to do moving forward. We can also look at the levels in blood, and this uses just a slightly fancier machine called a WES, and it gives you an output that looks like this, and it's basically a very similar thing. So the darker the blot here, the more is present. So these 2 have got lots, and these 2 not so much, and it just gives us an answer to how much is there in the blood and urine, which we can then use to identify which patients are active and which are maybe not. And then I want to look at the levels of complement in the kidney and what the complement proteins might be doing once they're there. And in order to do this, we get some cells. So these are actually kidney cells that have been taken from someone, and they're able to grow in the lab, and we can use them for scientific experiments. And this gives us an indication of what would happen in your kidney. So we can give them complement proteins directly, but we can also give them blood samples from patients who have the disease, and these would contain different levels of complement that we've found out in the last aim. And then once these cells have been treated with this, we can look at their genes and we can look at their proteins and just see what is happening inside the kidney and how damage is occurring. I'm also interested in what complement is being produced in the kidney. So to do this, we can take our kidney cells again, and we can just treat them with the blood samples this time. But this time, the genes and the proteins that we're looking at are the complement genes and the complement proteins. So we're seeing what is happening in relation to these proteins in the kidney and whether they are being produced there. The impact of this work would be that we could identify a potential test for kidney involvement, and that would be looking at these levels in the blood or the urine, depending on which one was better. But it also might identify possible treatment options for kidney involvement. So there are already medicines available that are used in other diseases that target this pathway, the complement proteins, but because we don't have enough evidence that they're involved, we can't use them in patients yet. So hopefully if we've got this this knowledge of what is happening, that will give us some indication of how we can maybe test these medicines. So as a research scientist, I'm also very interested in what we call the knowledge base. So this is just what is known about the disease. And the more we know, the more we can start to build a larger picture of everything that's happening. So just by doing this work and getting this knowledge out there, we'll be increasing the knowledge base, which will help other people look into the disease as well. And this also provides data, so we get data back from our experiments, and that helps us to plan future studies going forward so that we can look in other areas or look deeper into this area, and that just helps us to continue our research. Does anyone have any questions for me? I think you can pop them in the chat, or if Louise and Chloe, if you have any questions as well.
That's excellent, Rachel. It's really good to see what goes on in the laboratory behind the scenes, really. So how close do you think some of the tests looking at maybe complement are to being drugs or better treatments for patients?
Well, as I said, there are medicines that are already available. So really all we need is the evidence base. And there's also some other medicines that are in clinical trials for other diseases. So they're not standardly given to patients, but they are given to a controlled group of patients so that we can find out what they do. So I think these medicines are probably maybe 5 to 10 years away from having direct patient benefit, whether you could go to see your doctor and say you have this problem. They could say, well, I think these are the correct treatments. So not too long, but there is still a ways to go. Thank you.
That's excellent. Great.
Thanks, Rachel. I was just wondering, the kidney samples that you use, where do they come from?
So that's a good question. So as part of the EATC, Louise heads up the IgA vasculitis study. So when patients come to the hospital and they have IgA vasculitis, they are sometimes asked if they want to take part in the study. And then these patients are asked just to give a little bit of extra blood and urine samples if they're already having clinical samples taken. So we wouldn't be taking samples if they're not having anything, but if they're already having, we just ask them if they can give a little bit extra and we can take it to our labs. And then we have a team of scientists who process these samples, and we store them in what's called a biobank. So we have very large freezers that contain small parts of these samples, so that if people did want to do scientific experiments on them, they could request to use the samples first of all as part of the study, and then they can do their experiments on them. And it just gives a large view of what's happening, because we have lots of patients there. So it's not just looking in 1 or 2 patients, you're looking in a larger number to get a broader idea of what's happening in the disease.
Excellent, that's brilliant. So I think if there's no other questions, then we'll progress to the last section, really, which is the future and what does the future bring. And I'm going to present some slides just to go over that aspect. So what does the future bring, and what are we trying to do to improve things in the short term and also in the long term? So we know that we can improve, there are lots of ways that we could improve this disease, and we need to learn how we can do this and try and understand what the main problems are from patients, so that we can try and direct how we could improve things from what they tell us. As we've heard, there's still lots we need to learn about, both in the science data, but also in better treatments. And we need to find out which of the current treatments are the very best, and then which new treatments might show promise to make this condition better. So what we have is a program of work within the EATC group, and this is what we call the bench to bedside. So we look at the patients in what we nickname the bedside, and we look at how we can improve their clinical care. So how can we get doctors to give the very best care to all patients, no matter where they live, and how can we also tailor that care so that they get what they need, and how can we make that personalized so that if they've got more severe illness in, say, their tummy or their kidneys, then how can we personalize it so that their care is directed towards what they need. We also look, and we've heard a little bit about this, in the laboratory, so what we call the bench by nickname, and we try and look at how we can understand science to then try and help us understand the disease better. And ultimately what we're looking for really is better treatments so that we can treat people better and more precisely than what we do at the moment. And so to link into this, we're involved in making guidelines. We talked about ways to monitor the urine and pathways to do that. We also collect samples and DNA samples or blood samples across patients across the UK so that we can begin to learn more about bigger groups of patients when we put everybody together. And we've heard about some of our laboratory work, and locally we have the IgA vasculitis study where we ask patients if they'd like to take part in this study and contribute anonymous samples for a biobank. And then we'll talk shortly about how we want to evaluate treatments and get better treatments for this condition. So the most important thing that we do, and something that's at the very heart of the EATC as a whole, is that we listen to our patients. Our first patient involvement event where we had patients and their parents was about 8 years ago now, back in the day where we could all meet face to face, and it involved sticky notes and lots of workshops. And what we did at that time was just listen, and we heard about all of the issues that were arising from people who'd had IgA vasculitis. Since then, we've gone on to hold regular events, and these even include inviting children to the laboratory. And in the last year, we've had to move some of these virtually. And what we've learned over the years, and particularly in that first workshop, is the frustration with having to watch and wait for the kidneys to get inflamed, and what families described as the window of opportunity where we could hopefully be able to stop the kidneys getting inflamed during this period of monitoring. And we also learned from teenagers 8 years ago that if they Googled HSP, the first hit that came up was highly sensitive person, and there wasn't very much accessible patient information. And I'm very pleased to see that over the years we've improved this through links such as InfoKid and also our charity partners such as Vasculitis UK. And now if you put HSP in, one of the top hits you get are the patient support groups, which is really important. So we still want to learn more. Over the years, we've listened and we've heard noises that the kidneys have been the main issue, but also that there are problems related to the tummy and tummy pain, and people needing hospital admission for tummy involvement or tummy pain. And we want to try and begin to understand that and listen to patients who might have had problems with their tummy throughout the course of IgA vasculitis. And so we're holding a creative workshop in a few weeks, which is suitable for people of all ages, where hopefully we will find exciting ways to listen and to learn and to feed back to the rest of the EATC group about what the problem is with tummy and the tummy pain, and what opportunities are there for us to make this better. And if anybody listening to this either live or through the recording is interested in this event, then please do email us and register your interest. So I mentioned that we're trying to make things better. We're currently forming a working group to make some UK guidelines. These are based on some European recommendations, and we've been approved by the Royal College of Paediatrics and Child Health to be able to make these guidelines in partnership with their support, which is really important, so that we'll be able to get engagement from paediatricians across the entire UK. And hopefully these guidelines will be able to act as a kind of recipe for doctors to be able to follow if they had a patient who had IgA vasculitis, and it might not then be getting better, or it might have complications that they might not be familiar with. They'll have a guideline that they can go back to and refer to. But as part of this guideline, it's absolutely crucial that we write this in partnership with patients and parents or our support charities, and therefore we need help, and we're really keen to get people involved. So if anybody is involved in being part of the working groups that we're just putting together, and they'll form regular meetings over the next year, then please do get in touch, and we'd embrace the opportunity to hear the patient voice in these guidelines. So we need to prove that the treatments that we currently have do anything, and whether they work, so that we can justify the medicines that we're giving to people that might have side effects. What we have been looking at is the treatments that are used for inflamed kidneys, and we know at the moment that we treat patients once they've had a kidney biopsy and once their kidneys are quite inflamed already. And what we looked at is we looked at our UK data, and what we saw across the UK is that there were lots and lots of different ways that people were treating this condition, with about 15 different patterns of treatment medicines being used. And we don't know which of these is the best, and we don't know which might be working slightly better than some of the others, or whether they're all working exactly the same. And so what we did over the past year or two is we got lots of the medical literature and the information from the medical literature that's out there. We formed groups of professionals, both nationally and internationally. And we also listened to patients who'd been through having kidney biopsy proven IgA vasculitis. And what we formed together is what we call a clinical trial protocol, which has managed to get these 15 treatments right down to just a couple of treatments, where we can try and evaluate them in a much more controlled way by doing a treatment drug trial to see which one is the very best. And hopefully we're just under evaluation for funding for this trial, and hopefully in the next few years we'll be able to secure the money to be able to take this trial and prove which treatments are the very best. And once we can prove which treatments are the best, we can then look at how we can get them even better, or look at new treatments and whether the new treatments are even better than the drugs that we've got at the moment. So we also need to learn about why it happens. We've touched a little bit about the biology and the science that we're doing, but we still need to do lots more. We want to know whether there's anything in this IgA molecule that's different in patients that, say, might have kidney problems and might not, and whether we can begin to look at this at the very early stage to say, actually, yes, the way that your IgA molecule is made up means that you're more likely to get kidney problems than those who don't, or whether we can develop a test that can confirm that somebody's at risk of IgA vasculitis. And so what we're doing is working in partnership with scientists at a Centre for Proteomic Research at the University of Liverpool, where they can begin to look at the tiny, tiny parts of this IgA molecule and split it apart and see whether there are any differences in the tiny parts within this IgA molecule. And this is being done in partnership with Kidney Research UK, and has also been built from some early project funding that we had from our partners in Vasculitis UK. And so we're very grateful for our charity partners in the early science that we can do, and how we can hopefully begin to learn from the science to then get a test that would allow us to test which patients might be at more risk than others, or to confirm that they have IgA vasculitis in the first place when we don't have a test to confirm that. So the vision overall, and the kind of vision that drives all of the work that we do, is really that we want to move from this watch and waiting to getting inflamed kidneys, and we want to be able to predict and preempt and prevent this process happening, so that when patients present with IgA vasculitis, we can say, actually, yes, you're at risk of either having tummy involvement, kidney involvement, and we can tailor your treatment early on and try and prevent the damage that we see in some people who go on to have kidney problems. And ultimately, what we want is that nobody with IgA vasculitis should go on to get what we call chronic kidney disease, where there might be some damage in the kidneys. So just to summarize and to sum up our patient update event, IgA vasculitis is the most common type of vasculitis that we see in children, but it can present in any age. We see excellent outcomes for most patients, but there are people who get complications, and this is an important group that we want to try and improve their outcomes. There is the risk of chronic kidney disease, so kidney disease that isn't going to go away and might need treatment in the longer term. There is also the short-term risk of gut involvement that might need patients to come into hospital or might need more intensive treatments or investigations. There is very limited medical and science data, and this is something that we're really determined to improve. And what we need to do is continue to listen to patients, families, and work together with doctors, scientists, and everybody to try and improve things and make things better. And I really do think that there is much better outlook if we all work together for this condition. So just to finish and to summarize the whole event, really, if anybody is listening to this and is interested in any of the work that we're doing and interested in being involved, then you'd be very welcome, and please do contact us on the EATC email if that's the case. And I think I'll just hand back to the panel view where we can just summarize really and say thank you to everybody for listening, and thank you if you're listening on the recording, and sorry if there were any technical hitches, and we're still learning a year later about some of the technology that we've had to embrace, and thank you for your time really, and thank you to Chloe and Rachel and Laura for hosting. Thanks everybody. Bye now.